So I think this is very small curve which we can see, but with lorlatinib generally in our clinical practice, what we see is hypercholesterolemia, hypertriglyceridemia, and cognitive dysfunction, which is what we routinely see if you use lorlatinib. But most of this is fairly manageable with slight dose reduction or minimal dose interruption. With alectinib or quizartinib, most of the times you see transaminitis, visual disturbances, and sometimes diarrhea, which is seen with the earlier generations of EGFR TKs. And this is again the different side effect profile and the median duration of onset. The earliest complication that you might see is hyperlipidemia. Most of the times it's just it can be managed with the help of some lipid lowering agents. The other ones which are clinically important for us are psychotic effects and cognitive dysfunction. So this is a brief summary. So what at least I do in my practice whenever I start a patient on lorlatinib is check for a baseline fasting lipid profile. If it's elevated, I just start them on a small dose of rosuvastatin or atorvastatin. And then we monitor once every 2 to 3 weekly during the initial point of time. If a patient is having lot of hypertriglyceridemia, we try to temporarily decrease the drug or increase the dosage of the dyslipidemic drug. But even irrespective of that, if it's not managed, sometimes we tend to reduce the drug. Again, cognitive dysfunction is something many of these patients complain of memory disturbances. They have difficulty in recalling things, they forget things. But all of these are very small side effects. Sometimes you can just manage them with temporary discontinuation of the drug, decreasing the drug dosage. So many of these, again, this was explained in the WCLC 2024, and many of these patients, even irrespective of CNS side effects, they did not have any need for medical intervention. And this is what I've just basically described regarding the management of lorlatinib-induced hyperlipidemia. First, you monitor the lipid levels, you check it frequently. If it's way beyond the normal limit, you just hold it for some time, try to optimize the lipid levels, then restart it. And what is important is that irrespective of whether you have reduced the dose or maintained the same dose, the efficacy tend to remain same. So this is very interesting, and sometimes this can also be explored in the future, that maybe you can use a half dose of lorlatinib and you might get away with the same efficacy. This is important because it's a very expensive drug. It's almost around 1,20,000 per month, and sometimes for our patients it's very difficult to afford it. So if you can go away with 50 milligram dose, I think there is a small trial which is happening in the CMC Vellore also. So if you can go with a minimal dosage, that's very important to our patients at least. So this is data from the Indian subset, which was published in the ASCO 2025 as a poster. So this was published by Dr. Ullas Batra. So where they have tried around 91 patients with ALK-positive non-small cell lung cancer, and they have seen that the data tend to mimic the Western literature. The median age was 51 years. Many of them had metastatic disease at baseline. 49% of them had baseline intracranial metastasis. The objective response were almost to the tune of 75%. The major side effects which had happened was pedal edema, mood dysfunction, hypertriglyceridemia, and the response rate tend to be similar to that of the Crown trial. It's almost like 70% had a very good response to this. I think the PFS and overall survival data is still pending. So this is a brief, again, cross-trial and different comparison, where with the first generation you had only 10 months of PFS. With the second ones, it was almost to the tune of 2 years. Now with lorlatinib, median PFS is not reached, it's more than 60 months. Thank you. Thank you for it.